Okay, hello and welcome to the Health Show. My name is Sal DiBella. I'm the host of the show. And with me today is Deborah McGill. And we have a very special guest today. But for the people that are coming in for the first time and looking at our show, I just want to tell you a little bit about myself. I'm an author of 60 Doctors Talk About the Cure and Prevention of Cancer. Also, I just finished putting in another book that's called Doctors Talk About How to Reverse Diabetes. And that just went out about a week ago. I'm an author, a researcher, a hypnotherapist, and I have been helping people for over 25 years with cancer in New York. I'm just here in Massachusetts, I'd say about 4 years. And how I help the people in New York is through the mind-body connection. Getting rid of anxiety, depression, stress, dealing with their cancer diagnosis. And it really helped them tremendously. We taught them that you have to have a plan and a backup plan. We taught them to learn about their cancer. You know, doctors know about many different forms of cancer, but you know, you can learn about your particular type of cancer. So anyway, I moved and I'm here in Massachusetts, and we started a support group in the First Congregational Church in Boxford, and it's free of charge. And all of those 27 years, it's been free of charge also. And we meet once a month, the first Monday of the month. And that's also free. So let me just talk a little bit about our guest today.
And Sal, if I could interrupt just briefly, your emphasis in that first Monday group is nutrition, dealing with stress. Is that correct?
Yes. Mm-hmm.
Okay.
I'm very honored to have Dr. Nicholas Gonzalez with us today, I should say. I've known about him, I've heard about him many, many years ago. Unfortunately, never really met him. But I've heard in the 27 years I'm working with people in New York and Massachusetts, I've heard the name. If I knew him then, you know, I have a lot of people, including close friends of mine, that had pancreatic cancer that I wish I could have sent to him. So without any further ado, welcome Dr. Gonzalez.
Thank you so much for having me. It's a pleasure to be here.
Thank you. So we'll start right off with the questions. Now, you are a conventionally trained, aren't you?
That's correct. I went to Cornell University Medical College here in Manhattan. And I chose Cornell because it was associated with Memorial Sloan Kettering. That was one of Cornell's teaching hospitals. And from my second year of medical school, I was working under the then president of Sloan Kettering, Dr. Robert A. Good, who did the first bone marrow transplant in history. And I later joined his group. He was pushed out of Sloan Kettering. I followed him around the country, ended up in Florida, the All Children's Hospital, where he set up a bone marrow transplant unit, and he trained me how to do bone marrow transplantation. But he also knew of my interest in nutrition. So he encouraged that all the years I worked under him, beginning as a medical student. So he was a great mentor and teacher. He's now deceased. But he was considered the most published author in the history of medicine. And so under his direction, I learned how to do conventional oncology and even bone marrow transplantation, which is about as conventional as you can get and about as aggressive as you can get.
So how did a physician trained to do bone marrow transplants become interested in alternative approaches to cancer?
Some of my professors still wonder about that years later. I had some very wonderful professors who respected me, and two of them offered me positions at Sloan Kettering with the provision, this is after I finished my training, with the provision I would have to give up my crazy, controversial nutritional research. And I was very grateful that they would think that highly of me, but I, of course, had to turn them down to go my own way. I'm a very independent kind of guy anyway. I wouldn't do well in an institutional setting. I was preparing to spend my life in basic research at Memorial Sloan Kettering. I mean, that's why I went to Cornell. I could have gone anywhere I wanted. Chose Cornell because it was affiliated with Sloan Kettering. And for my second year, I was working under the president. My career line was set. But at the end of my second year of medical school, I had the opportunity to meet William Donald Kelly, who was the very controversial, eccentric dentist from Texas who had developed this aggressive nutritional program for the treatment of cancer and other diseases. And I met him through a circuitous route. I had been a journalist before going to medical school, and one of my journalism friends was thinking about doing a book about Kelly and wanted me to meet him. And I said, I don't want to meet this guy. He'd been involved with the Steve McQueen fiasco. I just thought this guy was some kind of crazy fringe dentist. He wasn't even a physician. She called me 3 or 4 times, finally said, I'll take you to lunch. I said, you don't have to take me to lunch. I'll meet him, just to get her off my back. I met with him, skeptically suspicious, and within 5 minutes I knew I was in the presence of one of the smartest men I would ever meet. And to this day, that was 1981, July 1981. To this day, I know at that meeting I was in the presence of one of the smartest people I would ever meet. He was a very humble guy, had developed this program, started out as an orthodontist, had pancreatic cancer himself, with no other treatments available, as you know, because you mentioned friends had pancreatic cancer. There was, and this is 1960s when he had cancer. There was nothing they could do. He had stage 4 disease. Cured himself with nutrition, and gradually his career path changed from the multi-million-dollar pathway of a conventional orthodontist to treating patients with nutrition who had cancer. And he was quite successful. And when I met him, his only wish was that his work be evaluated because he thought he had something useful that was being totally ignored by the conventional medical world. And the day I met him, I went up to see Robert Good in the president's office at Sloan Kettering, very elaborate office overlooking New York City. And I explained that I met Kelly, and he seemed to be very sincere and seemed, based on his history, had all these patients with advanced cancer appropriately diagnosed that had done well. And Dr. Good said, follow it up. Find out what's in this guy's office. And this is why Dr. Good was such a great mentor, because here was the president of Sloan Kettering encouraging a medical student to go track down an unconventional cancer quack. But Good's attitude was, even if Kelly turned out to be a quack, that I would learn a lot just by investigating his records. That was Good's genius as a teacher. More of Good's students have gone on to full professorships in medical schools in America than any other professor who ever lived. So he had a good track record as a teacher, although controversial because he supported people like me. The following day I was on a plane with Kelly to Dallas, Texas, where he had his office, and started going through his records. And within days I had dozens of records of patients with appropriately diagnosed advanced cancer, like stage 4 breast cancer, stage 4 pancreatic cancer, metastatic colon cancer, leukemia, who were alive 5 and 10 years later with total regression of disease that could only be attributed to Kelly's program. After 3 or 4 weeks, I went back to New York, met with Dr. Good, showed him some of these records, and he said he had never seen anything like it. I mean, he had to maintain his objectivity and his inherent skepticism, but encouraged me to continue while I was a medical student investigating Kelly's work. And then when I eventually joined Good's group as a full fellow, I had to do my bone marrow transplant responsibilities, but he also funded me to continue my investigation of Kelly. And I ended up spending 5 years going through thousands of Kelly's records. So that's how it started, as a simple student project where I reluctantly met this alternative cancer practitioner, and that meeting would change my life. From a very secure pathway at Memorial Sloan Kettering to being a kind of an outcast myself doing alternative cancer medicine, at least in terms of the conventional world. So that's how it started. But there was no question that Kelly was reversing advanced cancer. I went through 10,000 of his records, interviewed over 1,000 of his patients. We did an exhaustive investigation of Kelly's records, and evaluated 455 of them in great detail with multiple interviews. I even went to some of their homes, got all their medical records, eventually wrote up a monograph where I wrote up 50 different patients of appropriately diagnosed advanced cancer who'd done well under Kelly's care that were alive 5 and 10, even some of them even more than that years. Put it together in monograph form. Then in 1986, we couldn't get it published because in those days, if you mentioned nutrition and cancer in the same sentence, it was considered a sacrilege and a felony. So I tried to get it published for 2 years. Eventually, we published it in 2010, updated, rewritten with a new introduction, bringing it up to 2010, but we finally got it out there. So that's how it happened. A chance meeting with an alternative practitioner who happened to be passing through New York, who was meeting with a journalism friend, and changed my career, changed my life.
Mm-hmm. Okay.
Amazing.
You spent years investigating the work of the alternative practitioner, Dr. Kelly. What kind of results did you find in his practice?
Which he's already kind of talked about.
Yeah, we went, I evaluated 455 of his patients with advanced cancer exhaustively and found tremendous results. For example, one of his patients I still follow. In August of 1982, she developed digestive problems. Her local doctors in Appleton, Wisconsin, where she lived, thought she had gallbladder disease. And this is 1982, before they routinely did CAT scans. So they take her to surgery and open her up, and she's got a pancreatic tumor with metastases in the liver. They biopsy the liver lesion. It confirms pancreatic cancer. The surgeon closes her up and said, this isn't gallbladder disease. The local oncologist said he could offer her chemotherapy, but she might live, she might live 18 months if she were lucky. She goes to the Mayo Clinic where they confirm the diagnosis. And they also say, we could give you chemo, but it would be a waste of time. It's not going to cure you, and you should just enjoy your life. Well, she wasn't about to die. She and her husband ran a gas station in Appleton. She worked 7 days a week. She had kids and grandkids, and she wasn't about to die. So she learned about Kelly through his book in a local health food store, went on the Kelly program, and that was 1982, 32 years later, she's alive and well. She's never gone back to a conventional doctor, never had another scan, so we don't know what happened to the tumors. I know of no patient in the history of medicine with stage 4 biopsy-proven pancreatic cancer with biopsy-proven liver metastases confirmed at the Mayo Clinic, one of our esteemed institutions, who's alive 32 years later. And I searched the literature regularly. There's nobody like her. And this was a Kelly patient. I follow her now. She considers me her doctor. But we had patients like that just defy the standards of accepted medicine in terms of survivorship for pancreatic cancer and other cancers. The 50 cases we wrote up represented 26 different types of cancer. So we, across the board, from A to Z, Kelly was reversing advanced cancer. There was no question about it.
Mm-hmm. Now, did you say your 5-year investigation of Dr. Kelly hasn't been published, or was published?
No, it was published in 2010 as One Man Alone. Mm-hmm. It's available on Amazon, through our office, through the publisher, New Spring Press. So we did finally get it published. I tried for 2 years, but there were 2 responses from editors. And we went to trade publishers, we went to medical editors. First response is this couldn't be real because they just believed that nutrition couldn't reverse advanced cancer. That had to be fake. The second response is, we believe this, but if it's true, it's going to be so controversial, and my publishing career will be over if I were to publish it. So after 2 years of trying and approaching dozens of publishers, trade, scientific publishers, medical publishers, we just gave up. Finally, in 2010, as I got better known and people accepted our work more, we were able to get it published, and it's doing quite well. And patients appreciate it. Everybody who's interested in alternative medicine reads it, appreciates it, because it's a documentation of my investigation of Kelly, where we got permission from the patients to include medical records, so we include select medical records confirming the diagnosis.
Okay, can you sum up the basic components of your treatment?
Yeah, Kelly's treatment and our treatment today, which is a variation of Kelly's, involve 3 basic components. It's a complex program, but it can be summarized in 3 basic components. Individualized diet, individualized supplement programs, for cancer patients, large doses of pancreatic enzymes. And the third component are the detoxification routines, like the infamous coffee enemas. Now, Kelly's genius was he realized that one diet doesn't fit all. A lot of alternative practitioners treat everyone the same. The Gerson people put everyone on a plant-based raw foods vegetarian type diet. Atkins, whom I knew in New York, thought everyone should be on fatty meat. Reven out of Stanford thinks everyone should be on a Mediterranean diet. Kelly realized different people need different diets, and he had 10 basic diets that ranged from largely plant-based raw foods to an Eskimo diet, red meat 3 times a day, and he had 94 variations of the 10 basic diets. So each diet is individualized for each patient. Secondly, Kelly was famous, and we're famous, as the doctors that prescribe lots of nutritional supplements. It's true we do, but the supplement regimens are also individualized for each patient. We use different forms, different doses, different kinds of supplements for each patient that walks into our office. And we believe the vitamins, minerals, trace elements have a supportive role. We don't believe they're going to reverse advanced cancer. We also use glandular products from organically raised animals like adrenal and thymus, which are also supportive. But the main anti-cancer element in our program are large doses of pancreatic enzymes. Now, in conventional physiology, pancreatic enzymes have been known for over 100 years, and they're known to be our main digestive products. That's how we break down food, proteins, fats, and carbohydrates. But in addition to that, Dr. John Beard, the great he was English but taught at the University of Edinburgh in Scotland, the great researcher, first suggested in 1902 that pancreatic enzymes, above and beyond their digestive capability, represent the body's main defense against cancer and would be useful as a cancer treatment. And Beard was very well known in his day. He was nominated for the Nobel Prize in 1906 for his embryology research, but his cancer work even then was extremely controversial. And when he died in 1924, he died in obscurity. Occasionally, researchers like Kelly would rediscover Beard's work, and when Kelly was treating himself, he discovered Beard's work, added on lots of pancreatic enzymes, and that helped get him well. So our average cancer patient takes 100 to 110 capsules of pancreatic enzymes a day, spread through the day. So individualized diet, individualized supplement programs, large doses of enzymes, and the third component are the detoxification routines. Kelly learned early on, and we accept, that as the body repairs and rebuilds and as tumors break down, a lot of toxic debris is going to be released. We all live in a toxic environment. There are 79,000 toxic chemicals being released into the environment in the U.S., most of which have not been tested for safety. And even if you eat organically, there are heavy metals in the air. There's mercury in the air pollution in New York City. There's aluminum dust in the air pollution. There are pesticides in the air pollution. A lot of these hydrocarbons and toxic chemicals get stored in our cells where they sit like a ticking time bomb. On our therapy, as the normal tissues repair and rebuild, all this toxic debris is released, and it can become a little bit overwhelming to the liver and the kidney, which are the main detoxification organs. In addition, nothing is more toxic to the human body than dead cancer cells. So as the enzymes break down a tumor, you get all this dead tumor waste, which can also overload the liver and the kidney. So Kelly, when he was first developing his program, searched for simple techniques that would help the liver and the kidney work better to help mobilize the waste as the body repairs, as the normal tissues repair and rebuild, and his tumor breaks down. And he discovered the coffee enemas, not in some alternative journal, but in the Merck Manual, which is a textbook of conventional medicine. Coffee enemas had been part of conventional medicine for 100 years. And they were in medical texts and nursing texts right up until the 1970s. They were in the Merck Manual right up until the 1970s. So Kelly incorporated those into his program, and the thesis was that when you drink coffee, it suppresses the liver. But when you take coffee as an enema, it helps the liver work more efficiently, and that enables patients to survive the repair process and the detoxification process as tumors break down. And he added other things like a liver flush, which also helps clean out the liver, juice fast, colon cleanses, various types of enemas in addition to the coffee enemas, like a bentonite enema, bentonite's clay. So we have many, many different detox procedures, which we use today, and they're very effective. So in summary, again, the program involves individualized diet, individualized supplement programs with large doses of pancreatic enzymes for cancer patients, and the detoxification routines, including the coffee enemas.
You mentioned before Steve McQueen. Do you remember what his story was? I did a little research on him also, but do you?
Not only do I know the story, but about 50 feet from where I'm sitting right now in one of my storage rooms, we have his medical records. I got them from Dr. Kelly. I mean, I have a couple boxes filled with Steve McQueen's medical records from the time he was diagnosed. The true story, as you know, has never been told. Kelly got blamed for this, like he murdered Steve McQueen. No, it's a nonsense. It's an interesting story, which I discussed in One Man Alone, because at that time when I wrote the first edition of that book, first version of the book, it was still a hot issue. And to this day, Kelly gets blamed for the death of Steve McQueen. In the last few years, there have been 2 biographies of Steve McQueen. And lo and behold, Kelly gets it like Kelly took a gun and shot him. Well, this is the real story. McQueen started getting ill and went to his fancy doctors at Cedars-Sinai in Los Angeles. And they thought he had the flu or too much stress. No one took him seriously. For a year, they just blew him off. Finally, one of his brilliant conventional doctors gets the idea that maybe something serious is going on because he's losing weight, can't breathe, has a cough. They do an x-ray, he's got tumors in his lungs. It turns out he had stage 4 mesothelioma. Mesothelioma, as many of you realize, develops from exposure to asbestos. McQueen was famous for his motorcycles. He was a motorcycle racer, and in those days, they actually used asbestos to insulate the pipes in a motorcycle. And he was exposed to asbestos dust, and that's how he ended up with mesothelioma, and it was stage 4. Today, 30 years later, 35 years later, mesothelioma, when it's metastatic, is still completely incurable by standard medicine. It was totally incurable in those days, and it was beyond surgical repair because it was stage 4. It already metastasized. It was into his both lungs. It was even into the abdominal cavity. So one of his genius doctors in Los Angeles decides to give him immunotherapy. There's never been a study in the history of the world then or today that shows immunotherapy works with mesothelioma. It didn't work. Then the genius gets the idea to give him radiation. There's never been a study in the history of the world showing radiation reverses mesothelioma. All it did is make him sick. Finally, when he's near death, he goes to see Dr. Kelly. Kelly made one serious mistake with McQueen. He should never have taken McQueen as a patient. He was too sick, and he was a reckless guy. He smoked, he drank, he ate ice cream, but he was desperate. So Kelly, out of compassion, takes him as a patient, but he was too sick to do the therapy at home. So there was a hospital in Mexico that claimed to administer the Kelly program, at least part of it. Kelly sends him down there, and Kelly tries to direct the treatment. And he does better. I mean, he's still smuggling in cigarettes, and he was not a perfect patient, which was almost predictable by the nature of the life he led. He's smuggling Haagen-Dazs ice cream from San Diego into the Mexican clinic. But he does enough of it so he stabilizes and the tumors start to regress. Then one of the doctors in Mexico says we should operate and take out the dead tumor. Well, a day after the operation, which Kelly was against, he dies of not of the cancer, but of a pulmonary embolus, a blood clot that went into his lung, which is a post-surgical risk. He didn't die of the cancer. Actually, the tumor they pulled out, which Kelly used to have in his office in formaldehyde, was a dead tumor. And I have his medical records sitting in my office. And indeed, the story as presented in the biographies and the press were just totally misleading. The fact of the matter is, Kelly didn't shoot McQueen and kill him. No one ever blamed the fancy doctors in Los Angeles that misdiagnosed him for a year. No one ever blamed the doctors that gave him useless, worthless immunotherapy that did nothing. No one ever blamed the doctors that gave him useless, worthless radiation. They blamed Kelly when McQueen comes to him after all these geniuses had failed. So the story as presented is just nonsensical and has nothing to do with scientific fact. It has to do with the hysteria of conventional doctors against alternative medicine. As you recall, it was all across the media. In those days, there was no internet, but it was on all the major TV shows, in the major newspapers. The American Cancer Society held a press conference. Kelly is dangerous, killing people, as if they could get stage 4 mesothelioma well, as if his doctors in Los Angeles did anything correctly when they hadn't. So it was just a circus. And Kelly, in fact, in 1981, when I met him, was one reason he was traveling to New York. He had taken a train ride across Canada just to get away from the media, because 6 months later, he was still being tracked by the media. The National Enquirer had a reporter assigned to him taking long-distance photos at his home in Washington State. So he just secretly hopped on a train across Canada and was passing through New York and had spoken to the journalist who seemed fair and was a friend of mine, actually, who wanted to do a book on him. So that's the McQueen story, which has never really been adequately or honestly presented anywhere that I know of.
Right. Okay. I'm glad we got that out.
Did I answer your question?
Yeah,
okay.
Yes, you did. You did. What kind of results do you see in your own practice? Could you give us several examples of some of the successes you had?
Yeah, one of the great examples, one of my first patients, I remember so well, I saw December 3rd, 1987. I'd been in practice about 2 months at the time. Interesting story. 1985, she develops a mass in her right breast. Her doctor thinks it's mastitis. The breast is red, so he puts her on antibiotics. Doesn't work. Gets bigger. Finally, they sent her for a biopsy. It's inflammatory breast cancer, which is the most aggressive form of breast cancer there is. But by that point, the tumor is so big they can't do surgery. So she's referred to an oncologist who says, you have to have radiation to shrink the tumor, then we'll do a mastectomy. So she has the radiation. She's referred to a surgeon. They do surgery. The tumor is still 8 centimeters big, which is huge for a breast tumor. And she had 18 out of 18 lymph nodes were positive, which is an unmitigated disaster when it's that many lymph nodes. Every lymph node they took out had cancer in it. She had no evidence of metastatic disease, but they told her with inflammatory breast cancer, that size with 18 positive lymph nodes, this is a death sentence. We'll put you on chemo and keep you alive as long as we can. So they put her on a triple agent regimen of chemotherapy, initial CMF. And she follows that for 2 years. 1987, she develops pain in the chest. August, I think it was the summer of 1987. They do an x-ray. She got a tumor in her sternum. They do bone scans, multiple ribs involved with cancer. She developed metastatic disease while on aggressive chemo. Her oncologist, honest guy, throws his hands in the air, said, there's nothing we can do. This is the end. I'd been in practice 2 months. I didn't have a reputation. No one knew who I was. Bob Atkins had me on a radio show. Bob Atkins is the famous doctor, had a diet doctor, now dead, had a very well listened to radio show that was national. Had me on a show because he was a friend from my journalism days and knew about my Kelly study. He wanted me to talk about it just the way I'm talking about it now, 25 years later. And this patient's social worker happened to be listening to the Atkins show and heard it, and something about me resonated with the social worker who had a secret interest in alternative medicine. So she tells this breast cancer patient to see me December 3rd, 1987. I took a lot of faith to come see me then. I'd been in practice 2 years. Yeah, I was a smart guy, and I'd been trained under some of the best people, but I hadn't been in practice that long, and I was doing this unconventional therapy. Does the program religiously. First thing that happens, she doesn't die. She doesn't want any scans done. Finally, 2001, 14 years after she started with me, I convinced her, because I'm trained as an academic. At some point, I like to see some data. She lets me do a bone scan. Everything's gone. Well, she's alive and well. I saw her about 3 months ago. She comes in every 6 months for an office visit. She lives in New Jersey. She's now 26 and a half years out, almost 27 years from her diagnosis of stage 4 metastatic inflammatory breast cancer that failed chemo, not only failed chemo, but she developed metastases while on chemo. So there's a case 27 years out. I don't know of any case in the literature, and I keep up with the literature, of a patient like that with inflammatory disease that developed metastases while on chemo who survived 27 years with total regression of disease. So that's an example of a great case. Now, I have a whole bunch of pancreatic cancer patients who have been with me a long time. One of my favorite is a patient from Orlando. He was an interesting guy. He was trained as an academic. He had a degree in archaeology from the University of Paris, a graduate degree in archaeology, but then went into business and was very successful as a businessman. His wife had a PhD in English literature and was a professor, and then they retired to Florida. And like a good conscientious individual, he would see his primary care physician every year for routine physical, and they would do a chest x-ray. Well, August 1991, they do a chest x-ray. He's got a 6 millimeter, which isn't a very big, lesion in his right lung, and it looks suspicious. So the doctor sends him for CAT scans. Lo and behold, he's got the 6 millimeter lesion in his lung, but he also has a 5 centimeter lesion in his pancreas, consistent with a pancreatic cancer, 4 tumors in his liver, tumors in both adrenals, and bone metastases. They do a bone scan that confirms bone metastases, which is really advanced. They decide that the easiest tumor to access to get a tissue specimen is the lung, so they open up his lung, take out the lung tumor, and it confirms adenocarcinoma consistent with a pancreatic primary. They meet with an oncologist who is an extreme. I always appreciate honest doctors and honest oncologists. The oncologist said, chemo is out of the question. It's not going to work. It's going to ruin your quality of life. His wife, in tears, and they told me the story later, asked the oncologist, how long does my husband have? He says, maybe 2 months, because it's in every organ. Well, she was interested in alternatives and read an interview. This is, again, 1991. I've been in practice 4 years, not that long. She read an interview of mine in an alternative journal. It doesn't even exist anymore. And something, again, resonated. It's interesting how some people, they hear about our work and it resonates. Other people say, I'd rather be dead than take a coffee enema. Everybody's different. So they call us. We take him as a patient. And I'll never forget the first time I met him, fall of 1991. Here's a guy, 70 years old, stage 4 pancreatic cancer, given 2 months to live. And you'll appreciate this because of your work in mind-body. He was calmer than I was. And he wasn't, I knew he had graduate training in archaeology. He was an expert in impressionistic art, led tours at the local art museum. All this came out in his introductory notes that he had sent me before the visit. I knew his wife had a PhD in English literature. I wasn't dealing with dumb people that were ostriches with their head in the sand. About 20 minutes into the interview, I stop and I say, I got to ask you something. I said, you're calmer than I am. Because, I was a guy dealing with a stage 4 pancreatic cancer patient. He said, look, I read about you, I've met you, I've looked you in the eye, and he said, I trust you, and I know you're going to do the best you can do, and I'm going to do the best I can do. And this is the most important thing a cancer patient can learn. He said, I'm going to live each day as if I'm going to live forever. I'm going to continue to be active in my church, I'm going to continue to lead tours at the art museum, I'm going to do your program, and I may live 10 days, and I may live 10 years, but we're going to work together. There was no anxiety. Obviously, when he was diagnosed, he was distraught and fearful. That's a normal reaction. It would have been abnormal for him not to be fearful. But he got over it. He reached inside of himself, and I don't know where it came from, and he got to a level of peace and tranquility. In a state of anxiety, healing doesn't occur. As you know, the body breaks down in a state of anxiety. Anxiety is my greatest enemy. Cancer isn't my greatest enemy. My enzymes will kill cancer. It's the fear and anxiety around cancer that's my greatest enemy.
Absolutely.
He had mastered that, and he did great. Now, it's interesting. He did the program well. Every 6 months, we require patients from out of town to come back. He'd fly from Florida, and he looked great and was doing good. They gave him 2 months to live. A year passed, 15 months passed. His local doctors they think he's a miracle patient 15 months out. They want to repeat the CAT scans. And they repeat the CAT scans, and all his tumors are still there. The 4 tumors in the liver, the 2 adrenal tumors, the bone metastases, the pancreatic tumor, but they hadn't changed, which is a miracle, but they weren't gone. In fact, there was evidence of maybe a 5th tumor in his liver. So we meet and we discussed it, and I said, what do you want to do? He said, what we're going to do is you're going to change your dose of pancreas enzymes, and we're not going to do any more scans. And I started to laugh. I said, why is that? He said, all they do is create anxiety. CAT scans are not going to cure me. I don't need the anxiety, and I'm already outliving what they told me, so you're smart enough to figure out what we need to do, and let's forget about doing scans. It was probably the wisest thing a patient ever said to me. For the next 5 or 6 years, we did no scans. Finally, 1998, 7 years after he was diagnosed, he's leading tours in the Art Museum, active in the church, hadn't changed a thing, still living every day as if he were going to live forever, and he's starting to live forever. I say, I'm an academician. Let's see what happened. He said, Dr. Gonzalez, as a favor to you, I will do scans. I don't want to do them, but out of respect to you, I'll do them. So we did them. All his tumor, I have the reports. I sometimes use them in my lectures. The actual reports where the radiologist says, I don't understand what's going on. He had stage 4 disease. This is 1998 when we repeated them. Everything's gone. And I have his report. And we have slides when I lecture to show it, the improvement. He lived until 2006 when he was 85 years old. He didn't die of cancer. He died of the side effects of a car accident. He shouldn't have been driving at night at age 85, 86. Got in a bad car accident. His car flipped over, ended up in rehab, and died of the effects of the car accident at age 86. But he lasted 15 years with stage 4 pancreatic cancer with total resolution of disease, which, again, is unheard of in conventional medicine. But the interesting thing about this patient is how important the mind and the attitude of the patient. Yeah, I'm trained as a bone marrow transplant guy, and I believe biochemistry is wonderful and physiology I'm fascinated by. In the mornings, I read physiology texts. That's how I spend my mornings. But I learned from him and from patients like him, the single most determinant as to whether the patient does well or not is their attitude. Patients can have an early stage cancer, but if they live in fear and anxiety, nothing's going to work. My therapy, my enzymes, conventional medicine, it's going to be a nightmare, because in a state of fear and anxiety, the body's constantly breaking down. In a period of stress, the body breaks down tissues to provide energy to deal with stress. And for short term, that's great. But when it's prolonged, you're constantly breaking down your body tissues, which is the antithesis of healing. Healing, you want to build up the tissues. So anxiety, fear, lack of faith, lack of belief that they can get, well, all this creates the anxiety response, the stress response, which breaks down tissue and makes any treatment impossible to work. So from him I learned the value of peace of mind. And it's not naive, it's not a stupid that he's not aware of what's going on. He knew exactly what was going on. He looked in the oncologist's eye, and the oncologist said, you got 2 months to live. He knew what was going on. He's a very smart man, successful businessman, trained as a archaeologist. And he just had that sense in he got it from himself. Sometimes patients, as you know, need guidance. Sometimes they get it out of themselves, just the people they are. They rise to the occasion, like people that do heroic acts in times of stress. Some people can rise to the occasion, some can't. He rose to the occasion. A lot of our patients rise to the occasion. They just get over the fear and anxiety and believe that we're going to be able to help them well. Of course, I've been in practice 27 years, and people know that we have these long-term survivors. So they feel kind of relaxed coming into my office. We still get people with anxiety and fear that you have to deal with. Therapists can help. We advise them. Biofeedback is very, very useful for teaching people how to self-regulate their stress response. So although we treat people with enzymes and all those elaborate different diets and individualized supplement protocols and detoxification routines, all of which is wonderful, the single most important factor in a patient getting well is their attitude. And I've learned that from my patients.
Mm-hmm. Well, in all the years that I've been helping people, I've also seen that. I've seen the people that made it, and I've seen the people that didn't make it. Unfortunately, the people that didn't make it didn't have a good support system, like family backing them and good friends, and they didn't do any of the meditation. They said they did it, the guided imagery that I gave them. You could see the people that were going to make it and the people that didn't make it, you know. So to me, I think that's one of the biggest important things that a cancer patient has to do, and has to get that help right away. Because it's like when they find out, when a doctor tells them that they have cancer of any kind, what happens is that their head starts to spin. And they don't know where to turn, what to do. So after a day, 2 days, a week, they'll go maybe to a doctor, then to the internet.
Oh, gosh,
Okay?
yeah, the internet.
Yeah, they go to the internet and they try and find who's doing what, you know. This is why in my book, what I did is I made it easier for cancer patients. If I don't know if you've seen my book yet, but it's like a medical dictionary for alternative treatments, where there's that tells you about everything that has to do with alternative treatment, alternative doctors, alternative centers, and it's all broken down: coffee enemas, hemp oil, diet, nutrition. It has everything in there, and this is really why I wrote the book, you know, to make people aware of what's really out there and who's out there, you know, like yourself. You're in my book. So we'll go to our next question. I guess you still adhere to his treatment, Kelly's model in your therapy.
Yeah, our treatment is based on Kelly's model. I mean, we update it as necessary. I mean, when Kelly was in practice, for example, a nutrient like coenzyme Q10 wasn't even available. So as new information comes out about new supplements, we try and assess it and see where it will work in our program, where it won't. So we're constantly trying to revise it to the best available literature and scientific knowledge. But it's still his model, which really, really works with the individualized diet, the individualized supplements, detoxification, which I think is critical for success in any disease. I mean, I do them all myself. Never trust a doctor that doesn't live by his rules. I eat organically, my wife and I do. We both do coffee enemas. I take a huge batch of supplements designed for my particular needs. I've been on this program since Kelly put me on his program. He said, if you don't go on it, you won't understand it. This isn't some theoretical thing you can learn from a textbook. So I started doing coffee enemas a couple of weeks after I met him, just to see what the program was like. And I still do them today. Started today with a coffee enema 33 years later. So I follow my rules, and it really, really makes a difference in my own health. So yeah, our model is based on Kelly's model, absolutely.
And now, when a person comes in to see you for the first time, is there testing that you do with the patients? In other words, and if so, what type of testing?
Well, we require that all patients come to us with a diagnosis. And my average patient will come in with 100 pages of conventional medical tests. They've usually seen half a dozen conventional doctors, often many alternative doctors. So they'll come in sometimes with several hundred pages of records: CAT scans, bone scans, PET scans, ultrasounds, blood work. We treat other things besides cancer, like Lyme disease. I have patients with Lyme disease that have been treated by 15 different doctors, conventional, alternative, 100 pages of lab results on Lyme disease. So all our patients have to come with a diagnosis. They have to have testing. They have to have the standard testing. We approach our practice and our patients the way a conventional doctor would in some respects, in that we require they have testing. If a patient says, well, I have a breast lump, will you treat me? We'll say, no, you've got to get a diagnosis. I'm not going to treat you for cancer if I don't know what it is. So sometimes patients get upset with us. Well, you're turning us toward conventional medicine. No, we're just turning you towards sensible diagnostic tools. So they have to have a diagnosis. They have to have testing. And we, like the patient I mentioned with pancreatic cancer, in fact, he didn't want to do scans, and I had to argue with him to do it, and he finally agreed to do them. So we do the standard testing. We don't overdo. A single CAT scan can give you up to 1,000 chest X-rays of radiation. Right. A single PET scan, as good a test as it is, can give you 1,400 chest X-rays worth of radiation. So that radiation can cause problems. It's estimated 29,600 cases of cancer in the U.S. are being caused by CAT and PET scans. So that amount of radiation is carcinogenic. But they can be life-saving. If you have a patient with a brain tumor, you have to know what's going on. Fortunately, with brain tumors, you can use an MRI, which doesn't involve radiation. So we do use these tests. We do regular blood work. We also have a hair test that's experimental. We don't charge patients for it. We use it as just an adjunctive test, but we use the standard testing.
Now, besides cancer and what other types of problems could people have if they come to you?
One journalist referred to me as the doctor of last resort, and to some degree that's true. We see a lot of patients without cancer who have other serious illnesses, multiple sclerosis, chronic fatigue. I was never really interested in chronic fatigue. I was interested in cancer. When I started in practice, chronic fatigue hadn't even really been defined as a syndrome, and now it's well known and is epidemic. We have over 100 patients with chronic fatigue in our practice. Lyme disease is a big issue. You know, you're from New York. New York City is a major center of Lyme, this area. You know, Lyme, Connecticut, where Lyme was first diagnosed, is right up the road in Connecticut. Long Island, there are communities in Long Island where 50% of the people test positive for Lyme. And as early as 1988, when Lyme was first becoming a real serious chronic problem with a lot of patients, they started coming to me because no one could help them and the antibiotics hadn't worked. So we treat chronic Lyme, we treat chronic fatigue, neuromuscular diseases, problem patients where they've been to 15 centers and no one can help them, and 15 alternative doctors, no one helped them. So we see a lot of problem patients for whom no one else has been able to help. For example, one of my patients, wonderful boy, he was like 12 years old when he started with me, and his parents were desperate. They were seeing the best doctors in the New York City area. He had accelerated osteoporosis and terrible asthma. And he came into, I said, we'll take him because he's 12-year-old. You don't want this guy to, 12 years old, a male having osteoporosis. Comes in the office, and we do our workup, and we figure out what diet he needs and what supplements. But he had, because of his asthma, he'd been on high-dose steroids for years, and that's why he had osteoporosis. And to my absolute astonishment, every physician learns in medical school steroids can cause osteoporosis, but when you get in practice, they don't think about it. He was a 12-year-old kid. 12-year-old kids don't get osteoporosis. There's old women that get it, 75-year-old women and sometimes men. I took him off the steroids, put him on a program. His asthma completely resolved. Within a year, his bone was back to normal, and he's now an athlete. He couldn't perform in sports because he would fracture bones. He had multiple fractures. And his parents are really, joyful, and this goes back about 8 years when he started with me, so now he's going to college. And he was playing football and basketball. This is a kid with bones so fragile that if he kicked a football, he'd fracture his foot. So we see problem patients like that sometimes it's obvious that was the issue. But we also got rid of his asthma, which required certain supplements that worked really nicely. So we see a lot of problem patients for whom conventional medicine and other alternative doctors have not been successful.
Okay, you've published 3 books now, including your investigation of Dr. Kelly. Do you have any new writing projects at this time?
We have a major problem. It sounds megalomaniacal, but we think it'll be 3 volumes. And what it is, it's going to be initially it was going to be 120 cases, maybe 150 of our own patients. My Kelly book deals with Kelly's patients from 30 years ago. I've been in practice in the summer, it'll be 27 years. We started in the summer of 1987. So I've been in practice a long time. We have a lot of patients with me 20 and plus years. We consider, I give them credit. So when I say miracle patients, I'm not patting myself on the back. I always give the patient credit because it's their attitude that makes the difference. We have all these wonderful patients like the 2 I discussed, the woman with stage 4 breast cancer from 1987, the pancreatic cancer patient from 1991 who lived 15 years. So we're writing up case reports of it may be as high as 150, but at least 120 cases. It will probably be 3 volumes because each one of these stories is so interesting. As I go through my records, sometimes I forget what happened 20 years ago. As I go through my careful records, I remember how heroic these patients are in facing death and not giving up and not giving in to the conventional dictates that they're going to die soon and fighting the battle, sometimes against the opinions and the beliefs of the physicians, even family members. Gerson said he lost more patients to negative family members than he did to cancer, and there's some truth to that. Gerson had his own alternative therapy. He died in 1959, treated patients with nutrition with some success. And I think Gerson was right. So sometimes they have to fight family members. I think it's quackery, and go to Sloan Kettering if you have cancer. So we have all these wonderful cases of these heroic patients, these wonderful, extraordinary people who faced death and other serious illnesses and got well. And we're writing up, and it's just pleasure for me to write these stories. We protect their confidentiality, of course. We don't give their names or addresses or anything like that. But we're going to include records with their names blocked out to confirm that they had the disease. I say they would. And I've done about 95 cases so far, and I just keep going because I have so many wonderful patients whose stories deserve to be told. And the reason we did that is because we realized the academic authorities are never going to accept what I do, even though I come out of their world with a fancy Ivy League education. Well, so what? They don't care. They think what I'm doing is crazy. And we know they're never going to accept what I do, so we have to get the word out ourselves. And I estimate this may take 3 volumes, and it'll be our ultimate statement about this work and how effective it is. And in the introduction, I'm going to have a challenge to the conventional medical world. Match my cases. Very simple. 3 words. Match my cases. It's easy to criticize, easy to go on the internet and criticize. Talk is cheap. Match my cases. So that's going to be my challenge to the conventional medical world after the books are done. So that's the current writing project, which has been in process for a year and a half. It's a major job, and I also see patients 12 hours a day. But I'm getting it done. Fortunately, I'm on my programs, so I have great energy. So we're getting through it. But that's the big writing project right now.
Now, your treatment is a little bit close to the Gerson treatment. I also have them in my book. What is the difference between your treatment and their treatment?
I respect Gerson enormously. He was one of the pioneers. He was harassed endlessly. His daughter, whom I know quite well, thinks that her father was poisoned, and that's why he died with arsenic. And he certainly had the symptoms of arsenic poisoning. His grandson, Howard Strauss, is a good friend of mine. We're very close friends. And I respect them enormously, and they do good work. But there are major differences, and they know it. They respect me. I respect them. The Gerson people treat everyone the same. They have everyone on the same plant-based, organic raw foods diet. Kelly's genius was to realize different people need different diets. In anthropology, you have the Eskimos that thrived on an all-meat diet, 80% fat. The Maasai that lived on nothing but a gallon of raw milk a day. You had the descendants of the Incas that lived up on the high Andes that lived on a grain-based quinoa and corn kind of diet. And all these people did well as long as they followed the diet that they had adjusted to over the millennium. So our diet is varied. We don't just have one diet. We have 10 basic diets, dozens of variations. So that distinguishes us from the Gerson people. In addition, we use large doses of supplements where the Gerson people use some, and they even use some pancreatic enzymes, but not nearly to the numbers we use. They do the detoxification routines. Gerson was the pioneer about the coffee enemas, and I give him full credit for that. So in many respects, we're kind of descendants from the Gerson treatment in terms of the detoxification, which he realized as early as the 1940s was absolutely critical to get patients well, whether they had cancer or non-cancer. So in terms of detoxification, coffee enemas, he was there first. The similarities, the differences are we use different diets, not one diet, and we use larger doses of supplements than the Gerson people do.
Do you think conventional oncologists can match such cases?
Well, that's why in my introduction to the book that I'm working on now, I'm going to have that challenge. No, they can't. I searched the medical literature. Gemzar is the current accepted drug for the treatment of pancreatic cancer. It was approved by the FDA in 1998 after a clinical trial with 126 patients. Half got 5-fluorouracil chemotherapy, half got the new chemotherapy, Gemzar. And at the end of the study, the average survival had improved from 4.5 months to 5.5 months. Not a single patient lived longer than 19 months, yet that was considered such an advance. The FDA approved it immediately, and it's now a multi-billion-dollar industry. And that's the best drug for pancreatic cancer in the conventional medical world. And they didn't cure anybody. I went through Kelly's records as a medical student and found patients 5 and 10 years out with stage 4 disease. They're in my book, in the book on Kelly. We have patients been around, 15 years. My longest survivor with pancreatic cancer goes back about 24 years now. And I've not seen any cases that can match these, like the woman I mentioned that was Kelly's patient that I now follow from 1982, diagnosed locally, confirmed at the Mayo Clinic with a liver biopsy, stage 4, no question about it, alive 32 years later. Gemzar was approved. They had 126 patients. One patient lived 19 months. No one lived longer than that. 18% of patients lived a year, and they consider that a miracle. Average survival went from 4.5 months to 5, 1 month improvement in average survival, and it was approved. So the answer is, I don't believe the oncologists can match them, although I'm always willing to learn. If they can, great. We're going to challenge them to do that. But I don't think they'll be able to do it. I know they can, because I searched the literature.
Okay. Conventional scientists consider pancreatic enzymes as only digestive enzymes. Who first proposed that they have an anti-cancer effect? I
mentioned John Beard earlier. John Beard was an interesting fellow. He was born in England, trained at the University of London, got his PhD in Germany. In those days, scientists would go to Germany to do their postgraduate training. He got his PhD in 1884 from the University of Freiburg, and then got a position at the University of Edinburgh in zoology. He had an SCD, a PhD. He was trained as an embryologist, not as a cancer researcher. He wasn't a physician, had no interest in cancer, but his work in embryology led him through a circuitous route to the study of pancreatic enzymes through his work studying the pancreas in embryos. And in 1902, he proposed that pancreatic enzymes have an anti-cancer effect, and he was considered crazy. Then he did laboratory work. 100 years ago, 110 years ago, they actually had animal models for cancer, and he used them. There was a Jensen's mouse cancer, and he got 100% success in the animals getting the enzymes, and the control group with this particular type of cancer all died quickly. And then physicians who knew about Beard's work, because Beard was a very well-known scientist, as I mentioned, he was nominated for the Nobel Prize in 1906 for his basic science work, not for his cancer work. His cancer work actually probably kept him from winning the Nobel Prize. A number of physicians got interested in his work, both in the U.S. and Europe, tried the enzymes under his direction with total regression of disease. And I have a whole collection of articles from the British Medical Journal, from major journals, Journal of the American Medical Association from 100 years ago. But patients with appropriately diagnosed, and they knew how to diagnose cancer 100 years ago. They weren't living in caves. Memorial Sloan Kettering was already in operation. There were pathologists that knew how to identify the different types of cancer. And these doctors were treating appropriately diagnosed cancer with total regression of disease. And Beard documented these cases in a book in 1911 called The Enzyme Treatment of Cancer that we have reprinted as an exact facsimile. And that book should have changed the course of medicine, because not only did he have animal studies that proved the efficacy of the enzymes, but he had clinical data from human patients. In those days, there were no good treatments for advanced cancer. There aren't good treatments today for most advanced cancer. But Beard, with his enzymes, working with these physicians, he wasn't a physician himself, but working with doctors, was seeing reversal of advanced metastatic disease, colon cancer, breast cancer, rectal cancer, uterine cancer, the worst cancer killers, with success. His work was forgotten because Madame Curie, at the same time Beard was operating, said radiation was a simple, easy, non-toxic cure for all cancer. She was as brilliant as she was, and she won 2 Nobel Prizes. She completely misjudged the toxicity of radiation, the fact that just because a tumor shrinks in an animal doesn't mean it's going to cure cancer in humans. Very few cancers actually respond long-term to radiation. Usually it comes back more aggressive, and there's a terrible price to pay. In fact, Madame Curie learned that lesson because she died herself from the side effects of radiation exposure. They were very cavalier in those days. They would handle radium. They thought it was safe. It was invisible. How could it be dangerous? Well, she died as a result of exposure to radiation, along with a lot of her colleagues. But by the time Beard died, people already had forgotten him, and radiation was still considered the exciting new treatment. And it took people like Kelly to rediscover his work. So it was John Beard, working at the University of Edinburgh, that first suggested pancreatic enzymes have an anti-cancer effect.
Okay. Do you see any changes in the attitude of conventional physicians towards alternative approaches, such as yours?
At the highest levels of the academic world, at the highest levels of Sloan Kettering or the NIH and the NCI, I haven't seen any change at all. In fact, we got funding to do a clinical study that was completely undermined at every level. It was an NCI, NIH clinical study. And 8 years of work, thousands of hours, just totally wasted. And at every step, it was mismanaged or undermined. And I wrote a book about it, What Went Wrong, which is about how the government authorities and the scientists in charge of the study completely mismanaged, and whether it was deliberate or not, the reader can make their own decision. But it was a complete fiasco. So at the highest levels, no. But in terms of practice in oncology, practicing oncologists have a very tough life. Most of my patients get well. Most of their patients die. They work very hard. It is not an easy life. You're dealing with very sick people. On Friday evening, I'm in my office returning phone calls. Saturday, I'm in my office. Because these are very sick people. Tonight, I'm going to have to return 15 phone calls. I have people all over the world. A lot of them are very sick, facing death, and they need medical management. And oncologists have a very tough life, and that their rewards often are minimal because most of their patients actually die. And a lot of them are open-minded, particularly the younger ones. And we have very congenial relationships with a whole batch of oncologists. Now, 20 years later, I can't say we had a congenial relationship with any oncologist. They just considered anything that was not standard was fraud, quackery, stealing money from unsuspecting cancer patients, all the usual gobbledygook. That attitude has changed among the practicing oncologists, although I can't say I see any great change at the highest levels of the academic medical world. The former head of the NIH, the NCI, they knew that my study wasn't being managed properly. They did absolutely nothing. They could have cared less, is the attitude that I saw. But among the practicing oncologists, these people want to get their patients well. their vested interest is helping their patients. These are really, I know a lot of them. They're compassionate, they're concerned, they're frustrated, they work hard. They're not getting rich off of this because, reimbursements for conventional medicine is constantly going down. They're really devoted, and we're working more and more congenially with conventional oncologists. So I think among the practicing doctors, there's been a change. Also, the younger doctors, they're eating organically and they're making carrot juice. And the Cleveland Clinic recently was in the Wall Street Journal of all places. They've opened up a herbal center at the Cleveland Clinic, one of the preeminent orthodox conventional medical clinics in the world. It got a lot of media play. It was on the TV news here in New York. They have a herbalist there. They have an herbal pharmacy at the Cleveland Clinic. So there are changes, maybe even with the academic medical world, we're starting to see changes. In terms of cancer, I can't see that yet, but clearly there are open-minded physicians in the academic centers that are starting to look into unconventional medicine.
So in your opinion, you don't think your approach will ever be accepted into mainstream medicine?
Not while I'm alive, I would suspect. But that's one reason we're doing that 3-volume set of 120 or maybe 150 cases, is we're trying to get the word out there. So honest physicians and oncologists with an open mind can read the cases and see the records and we're doing very detailed case histories. Some of these are pages long, so people get the whole details of what happened. And they may get interested. But it's got to come from the patients demanding it and the practicing oncologists in the field, not from the academicians are so vested in their own egos and their own position. They don't want to be told, that some guy doing coffee enemas knows more than they do. It was very interesting. When I left Dr. Good's group, I'd finished my fellowship with him, and he'd been pushed out of Sloan Kettering. In fact, there's a book called Racketeering in Medicine by Dr. Turner. He has a wonderful introduction. He studied under Dr. Good before I did, when Dr. Good was still at the University of Minnesota. And in his introduction, he said he thinks one of the reasons Dr. Good was pushed out of Sloan Kettering is because he supported my work when I was a medical student and other controversial work. And maybe that was part of it. I don't think I was that important, but Dr. Turner thinks I was. Nevertheless, that I don't know that things are going to change in my lifetime. That's for sure.
Okay. I want to switch you over to Deborah. I met Deborah about a year and a half ago, and I met her. She had stage 3 ovarian cancer, and she did some of the treatments, that are out there today, as far as alternative treatments right now. But I'm sure she has a lot of questions for you, so I'll turn this over to Deborah.
Great.
Thank you, Sal. And this is not an unofficial consult, by the way. I just thought I'd clarify that. But just general questions, because I've certainly studied your program, fairly extensively, and I've worked along for about 6.5 years with my diagnosis since January of 2008, and I've used, I've had about 5 intravenous chemos and different types, and then 1 clinical trial drug, which was a PARP inhibitor, which you probably heard of, and so I guess my question is, and in fact I did apply to your program back in 2011, or I began to, and then I just kind of shied away for just different reasons. I just wasn't sure I'd be able to pull it all off. But now I've done harder programs than yours, believe it or not, alternative programs. And so one question is, you've said that people who've had a number of chemo regimens before they come to you, the road to regression of disease has more ups and downs. Can such patients still ultimately realize a goal of being cancer-free? And could you comment on the journey of these patients as they work through your program and your protocols?
Yeah, I mean, the patient I mentioned with the breast cancer, she was on CMF, cytoxin methotrexate 5-FU, which in those days was the standard multi-agent aggressive treatment for breast cancer. She was on it for 2 years and developed metastases while on chemo. So she had aggressive chemo. She got well. And many of the patients we see with breast, colon cancer, ovarian cancer have been treated with chemo before they get to see me, and it didn't work, and that's why they come to see us. We do see patients when they've been first diagnosed, if they have a predisposition to alternatives, but often they've already been treated with chemo. And they can get well, it's just tougher. As the Gerson people will say, when you've had aggressive chemo, it often doesn't work, but also damages the healthy tissue. So you're fighting two battles, the damage from the chemo and the cancer as well. But the program is aggressive, and many of these patients get through it. They have ups and downs because a lot of chemo, we believe, stays stored in the body. So on the program, as the body starts releasing chemotherapy from the cells, as it does as part of the healing process, patients will have some symptoms that are similar to what they had when they had chemo, not that serious. So it's a little rougher road than if they never had chemo. I have a patient with ovarian cancer, started with me in 1992. She was a nurse. She had stage 4, was in her liver. She had been an oncology nurse, and she knew that chemo would not cure liver metastases in 1992. And she came to see me right after surgery. They took out a 14-centimeter tumor just because they're afraid of an obstruction. And within a couple years, that tumor in the liver was gone, and she's 22 years later alive and well. It was, I won't say it was easy. Her case was complicated. We were talking about Lyme disease. She lives in the New York area. She had Lyme disease, so we had to treat that too later, but she'd been on the program for several years. But she had a less intense reaction as she did the program initially than patients with ovarian cancer that have had chemo like yourself. They can still get well.
Yeah, thank you. I guess one of the questions I would have would be, how would you alter the treatments you've described for us, for someone of that, in that category?
What we often have to do is get more aggressive with the detox. We don't back off on the supplements. Sometimes we do. Okay. For example, if a patient's getting really toxic and they fatigue, malaise, fevers, which they can get. Gerson talked about fevers 50 years ago. The patients often, as the tumor breaks down, get fevers. As they release chemo, they can feel sick again. We'll stop the supplements for a while. We do that actually with all our patients, but we'll stop it sooner with a patient who's had chemo if their symptoms get too severe. So we have all these ways of monitoring them and managing the program. Usually we'll put patients with cancer on a 25-day cycle where they'll be on the pills for 25, off 5. Everybody gets a break. Even I do that after 33 years. With patients who've had a lot of chemo, we'll often do 25 on 5 off, or even 15 on 5 off, because they get too sick too fast, and you have to slow down the rate of repair. Right. So we become experts in managing all this. Each patient we monitor individually, we manage individually, and we adjust the program as we need to.
Right, because I would imagine that managing that type of intensive detox would be a real challenge with this type of patient.
If you don't have the experience doing it, it can be a problem for the practitioner. But we've been through so many different situations. My colleague and I, Dr. Isaac, we have the knowledge base so we can work through those patients. We don't just keep pushing. If a patient's getting sick, we back off. Sometimes less is better than more, and we know that. I learned that from Kelly. I learned that from Gerson reading his book, from talking to his daughter. So if a patient gets too sick, we'd say stop all supplements for 5 days. And sometimes they get nervous. Well, these are the things that kill cancer. Yes, the trouble is you're killing too much cancer. You're getting too sick. Yes. You're releasing too much chemo. Back off. So they do that, and they feel better. Yes. And we'll have them do more enemas. Gerson sometimes would have people do coffee enemas every 4 hours. We'll sometimes do that with patients. So there are all these tools that we use and management skills that we've developed to help manage patients who've had aggressive chemo and aggressive cancer at the same time.
Right. I wondered as well what factors you incorporate when you look at all these different variations of diets. You said there were 94 different variations. Is one of those maybe blood type, rate of metabolism? Are those some of the factors?
I think Diabella, who wrote the blood typing book, deserves credit because he realized, unlike a lot of alternative doctors, different people need different diets, and he had a plant-based diet, a meat diet. I credit him for that. Kelly knew his father. Kelly never believed blood typing was that accurate. I never do it. I don't find it useful. Kelly had his own system of evaluating patients' needs. But, again, I've been doing this for 27 years. After a while, you have a clinical intuition about what diet a patient needs. We do have a specialized hair test that tells me which of the many diets, based on the biochemistry of the patient needs. So we have tests that objectively tell us. But you can do it from experience. For example, Kelly realized 40 years ago that patients that get the typical solid tumors, like tumors of the breast, lungs, stomach, pancreas, colon, liver, uterus, ovaries, prostate, always need to be on a plant-based diet. Patients with the immune cancers, leukemia, lymphoma, myeloma, sarcomas, which are connective tissue cancers, always need to be on more of a meat diet. People that really need a balanced diet, plant foods and animal product, they don't tend to get cancer. Cancer tends to happen at the extremes. People that need a plant-based diet or a meat diet, people in the middle don't tend to get cancer. They get other problems like chronic fatigue. So just from the type of cancer a patient has, you have already an idea of what the basic diet should be. But then the testing we do, even from the blood work, we can tell. Kelly had his own way of evaluating blood work, standard blood work, to determine what kind of diet a patient needs to be on. He was very sophisticated in terms of his interpretation of blood work. So we use these different tools, and we get a very accurate assessment of which of the many diets the patient needs to be on. So there's no guesswork involved.
Yeah. I'm curious too, when you have people on raw food diets, or even a partial raw food diet, what are the percentages of raw food that you incorporate? Could it be?
They vary from about, rarely do we put people on a pure raw foods diet, which is very popular right now. But Kelly had diets that range from 90% raw to 100% cooked. Now, it may seem like sacrilege to say some people need cooked food. Kelly realized early on, raw food is wonderful. Yes, I've written 3 introductions to raw foods diets. So I know raw food has all the vitamins, minerals, trace elements. Raw food has lots of enzymes. Edward Howell was the great American researcher that spent 50 years studying the value of raw food. And he said, in addition to the vitamins, minerals, trace elements, raw food has lots of enzymes as part of the normal metabolic machinery of the cell, whether it's from a plant food or an animal product. Every cell has hundreds, even thousands of enzymes as part of the cell's normal metabolic machinery. And he said those enzymes could be absorbed like a vitamin or mineral, help the body repair and rebuild. The trouble is they're very heat sensitive. Above 117 degrees Fahrenheit, all the enzymes in food are neutralized. So he considered it dead food. Now, Kelly realized that, but first Kelly was supplementing his people with huge amounts of supplements and enzymes to make up for the loss. But when you cook food, although there's nutrient loss like vitamin C is destroyed, folic acid is destroyed, calcium becomes less available in cooked food as opposed to raw. And even though the enzymes are lost, you're basically breaking down the cell walls, so it's like predigested food. For a lot of advanced cancer patients, particularly those who have had a lot of chemo, they don't really do well with raw food. Their gut can't handle it. You give them cooked food, it's like predigested, and they do great with it. And one reason juicing is so important, although that's a raw food, what people say, why should I juice? You get rid of the fiber. Well, you get rid of the fiber, all the nutrients are concentrated, and it is pure raw. And without the fiber, it's like predigested food. So even really sick advanced cancer patients whose gut has been destroyed by radiation and or chemo can absorb the nutrients very easily because it's like predigested. Cooking food has the same effect. You're basically breaking it down. So you compromise the nutrient loss for the value of the fact some people are too sick to tolerate raw. And the idea that everyone does well in raw, we have not. Kelly didn't find that to be true, nor do we. In fact, I myself, I'm kind of a balanced, slightly on the meat eating side. I don't do well on all raw foods. Of course, I experiment with all different types of diet. I need about 50% cooked, 50% raw, and on that I thrive. My wife does better with more raw. So different people need different amounts of raw versus cooked. So not only do we use different diets, within each diet category we have different percentages of raw versus cooked, which we work out depending on the history and the different testing that we do.
That's wonderful. Now, do you have any thoughts on patients eating raw meat? That's gaining in popularity these days.
Yeah, it is. Well, of course, raw meat will have the enzymes too, and steak tartare is a French treat, and I've eaten steak tartare, and I love it. It's wonderful. So you just have to be careful. You have to know the source, otherwise you run into parasite issues, as Hulda Clark would have said. Now, to see, she was a big thing about raw food has parasites. So she's the opposite of raw food. She thought everything should be highly cooked because of the parasite. Well, if it's properly raised and it's grass-fed beef, and they're not feedlot animals where they're exposed to their own feces up to their ankles and their knees, usually it's safe. And I eat steak tartare from restaurants that I trust, I know it's good quality meat. So yeah, raw meat is good. Wild animals in nature, carnivores like wolves, coyotes, lions and tigers, they don't cook their meat. They eat it raw, and they do just fine. If you ever doubt the ability of an animal to live on raw meat and survive without heart disease or anything else, it'll just walk into a cage with a lion or a tiger, see how strong they are. And they eat nothing but raw meat. In fact, zookeepers and zoologists learned 80 years ago, they have these expensive Bengal tigers that would cost $20,000 even in the 1920s. They feed them cooked meat, and they would be dead in 6 weeks. It has to be raw. So, lions and tigers in nature eat nothing but raw meat, and they do just fine.
Sure.
And their own body seems to handle the parasites pretty well.
Yeah. Thank you.
Okay, is there anything that we didn't cover that you would like to say? We don't have much time, so this is why I say that.
Well, I think you did a great job, and somehow we covered a lot of ground very exhaustively. I think we did a
Yes.
great job. Is there anything on my list of questions that we might have missed?
No, no. One thing, how can people get in touch with you? I know you're on 36th Street in New York.
36th Street. We're at 36, easy to remember, 36 East 36th Street between Park and Madison, Suite 204. But we have a website that everyone goes on computer now. The website is www.dr-Gonzalez. My name is spelled with a Z at the end, GONZALEZ.com. So it's www.dr-Gonzalez.com. There's an enormous amount of information on the website. There's also a section, how to become a patient. For anyone interested in becoming a patient, there's a section there, how to apply. We don't take all people. First of all, we try and be very honest. If we don't think we can help, we tell people, which sometimes gets them upset. But if you can't eat, you can't do our program. If you're getting chemo, you shouldn't combine our therapy with chemo. Wait till you finish chemo. But all that's discussed in the section on how to become a patient. So that's the best place. We have our books out, The One Man Alone, which is my investigation of Kelly, Trophoblast and the Origins of Cancer, which is about Dr. Beard from the perspective of modern molecular biology. And What Went Wrong was about my the disastrous attempt to work with the academic authorities on a clinical study. And then the book on the clinical patients, our own patients, will probably, hopefully, be done in a year, year and a half. It's a long 3-volume set, but we're starting to see the light at the end of the tunnel. But there are 3 books out now which has information about what we do. But our website's the best place to start.
Okay. And on my Facebook page, I let everybody know that I was going to interview you today. And I had a number of different questions that people have. Unfortunately, we don't have the time today. But, maybe down the road, if you'd like to do this again, we'd love to have you back on our show.
It was great fun. I'd be happy to do it.
Oh,
and next
great.
time I'll try and plan my time so I don't run so late with a patient.
That's
But
fine.
it worked out okay. It worked out okay, correct?
Yes, it did.
Yes.
Yes,
Good,
it did.
good.
So I want to thank you very much for being on our show, and we look forward to seeing you again the next time.
It would be my pleasure to do it, and thanks for letting me talk so much about what we do.
Okay, thank you.
Thank
Okay,
you.
you take care. Bye-bye.
Bye-bye. So that was Dr. Nicholas Gonzalez. Very interesting doctor. I would give him a call. I mean, he's had a lot of success with cancer patients. I think it's worth a call, to give him a call and talk to him and see if you qualify, for his treatment. And I want to thank you. We want to thank you for joining us again, and I'm sure this was very informative for you. And it seems like each week we have people that are really informative, and today was proof of it. And we'll see you the next time on The Health Show. Thank you.